This chapter is over the urinary system. Kidneys are the primary organ, functional organ of the urinary system, and the kidneys filter 180 liters of blood daily, and this is fluid that's derived from plasma. And the kidneys also regulate the total water volume and solute concentration of the plasma, and they also maintain a proper balance between water and salt, so your electrolyte balance, also acid-base balance. They remove metabolic waste, toxins, drugs, and also produce this localized hormone called renin, and they also activate vitamin D. So those are the primary functions of the kidneys. Now, one of the major things that the kidneys do is they take care of nitrogenous waste. Now, nitrogenous waste comes from proteins because nitrogen is found in proteins. You don't find this in fats or carbohydrates, but you do find this nitrogen group. It's called an amine group on your amino acids that make up proteins. And they convert this amine group to ammonia. This happens in the liver, and then the ammonia is converted to urea. So urea goes out in urine. So that's from protein metabolism. The other things that are considered nitrogenous waste are creatinine and uric acid, and that's from nucleic acid and creatine phosphate metabolism. Remember creatine phosphate? That's found in muscles. So there's a certain amount of creatine that's normally found in the plasma and normally is excreted in urine. Any elevations could indicate some type of problem with either the kidneys or could represent a muscle disease where muscles breaking down. Now, how you measure urea is through a test that's involved with a chem panel in the clinical lab, and that's called blood urea nitrogen. Now, there is a carrying load of urea in the plasma, and that's 10 to 20 milligrams per deciliter. So if you have an elevation of this, then that is called azotemia, and that's an accumulation of nitrogen-bearing waste products in the blood. Now, if you have a continuation of increased urea levels, this is called uremia, which is the pathological condition. And that results in blood poisoning and the sickness associated with having too much urea in the blood. That can be an indication of failing kidneys. So it causes diarrhea, vomiting, difficulty breathing, cardiac arrhythmia, and this requires dialysis or a kidney transplant. So failing kidneys could be potentially lethal if you don't do something about the issue. All right, so this is the location of the kidneys. So they're kidney bean shaped. They're about 5 inches long. They're in a retroperitoneal position, so they're behind the peritoneum. That's that serous membrane that lines the abdominal organs. They're in the superior lumbar region, and they extend from the 12th thoracic to the 3rd lumbar vertebrae. Now, the right kidney is a little bit lower than the left because it's crowded by the liver. The lateral surface is convex, and the medial surface is concave. So just giving you some general characteristics, and here they are continued. The adrenal gland is also called the suprarenal gland. That's on top of the kidney. The renal hilum is in the concave surface where your circulations come and go, your ureters exit, and your renal artery comes in, renal vein leaves. So that's where the renal hilum is, where these circulations come and go. Okay, so when we talk about the kidney anatomy, there's a capsule that supports the kidney. The renal capsule helps to spread the infection to the kidney if you do have an infection in the peritoneal cavity. There is an adipose capsule that surrounds the renal capsule, and it's fat that cushions the kidney and helps attach it to the body wall, because the kidney is mostly in an exposed position, because you remember it starts from the 12th rib and then extends down to the 3rd lumbar vertebrae, and what happens is that the kidneys are exposed. So they're susceptible to injury. So any type of trauma to the outside could very easily injure the kidney. So these protective layers are very important. The fascia is a connective tissue layer that anchors the outer layer of the kidney to surrounding tissue. Here's the internal anatomy of the kidney. And first of all, you'll see that it's separated into two regions. The outer region is called the cortex, and the inner region is called the medulla. And the medulla is made up of these triangular structures that are called pyramids. And the pyramids are made up of collecting ducts. So when we talk about the structure of the nephron is the structural and functional unit of the kidney. The collecting ducts all come together here. And then those collecting ducts will drain into this open area that's called a minor calyx. There you see it. At the end of the pyramids, there's like a little funnel that's called the papillae. So you see the papillae at the end of the pyramid, then it drains into a minor calyx. Then you have larger opened areas that are called a major calyx. And then you drain into the renal pelvis. And then from the renal pelvis, you go into the ureters. So that actually represents the flow of urine once it's produced out of the kidney. So those are all your internal structures and how the flow of the urine is conveyed out of the kidney down into the ureter. So a homeostatic imbalance of the kidneys. Pyelitis is an infection of the renal pelvis and the calyces. And if the infection radiates through the entire kidney, then that's called pyelonephritis. Because most of your nephrons, those are your filtration units that we're going to talk about in a minute, they're located in the cortex. So that's an infection or inflammation of the entire kidney. Kidney infections are normally successfully treated with antibiotics. Now, the blood supply and nerve supply to the kidneys, the kidneys filter quite a bit of fluid. Actually, they filter 1/4 of the actual cardiac output each minute. So about 1,200 milliliters of plasma is filtered through the kidneys every minute. So the kidneys are important for cleansing the blood. They adjust its composition, so there's a rich blood supply. Renal arteries are one of the biggest arteries that you find in the body, outside of the ones that come off the top of the heart. Arterial flow into and out of the kidneys follows similar pathways. And the nerve supply is by sympathetic fibers from the renal plexus. So here's the flow of blood through the kidney. Aorta, then you branch into the renal artery. The renal artery branches into segmental arteries that go in between the pyramids. Those are interlobar arteries. Then there are arteries that run perpendicular to these, and they actually occur in the margin between the medulla Like I was saying, the arcuate arteries are between the medulla and the cortex, and then they branch into cortical radiate arteries that go in between the nephrons and the cortex, and then they drain into an afferent arteriole that will enter into the capillary bed of the nephrons. And there's 1 million nephrons for each kidney. So these little filtration units, they're called, the capillary bed is the glomerulus, and then exiting the glomerulus is an efferent arteriole, and then you go into peritubular capillaries that surround the nephron, and then cortical radiate arteries back to the arcuate vein, interlobar veins, renal vein, and then out into the interior vena cava. Notice something interesting here. You have an artery coming in to a capillary bed and an artery going out. Usually you have artery, capillary bed, vein, right? This is different because what you're doing here is you're filtering the blood. You're not delivering the nutrients. You do that later on after the filtration process has occurred. Okay? So that's the circulation. Now, Nephrons, as mentioned earlier, are the structural and functional units that form urine, and you have about 1 million of these for each kidney. These are little tiny strainers. They're made up of simple squamous epithelium, and they have fenestrations, they have pores, so they're more porous than your normal capillary beds in the systemic circulation. There's two parts to the nephron. You have the renal corpuscle, which is made up of the glomerulus. Those are the capillaries, with a little capsule that goes around it. The filtration occurs here. And then you have what's called the renal tubule. So this is a look at the kidney again. There's the cortex, and they've taken a little section out to show you what the nephron looks like. So this blood vessel here, remember I was talking about those perpendicular arcuate arteries and veins that run perpendicular in between the medulla and the cortex. So arcuate, then you have cortical striated arteries, and then your afferent coming in. There's your glomerulus. Now the glomerulus inside here, this is the whole, this is the capsule that surrounds it. The glomerulus looks like a fist almost, right? So those are your blood vessels. That's the glomerulus. This brown thing or tan thing is the capsule that goes around it. Those two things together make up the renal corpuscle. And then these are parts of the tubule. This is called the proximal convoluted tubule. Then you have what's called the nephron loop, also called the loop of Henle. And so this is the descending loop. This is the ascending loop of Henle. And then you have the distal convoluted tubule. And these drain into collecting ducts. Now if you remember, I told you that the collecting ducts all come together in the pyramids. And by the time you get to the collecting ducts, most of what's in here is going to go out as urine. And remember that all those collecting ducts are gathered together in the pyramids, and then they drain through the papillae, minor calyx, major calyx, renal pelvis, and out the ureter. Okay, so that's really important, and the parts of the kidney tubule are important as well. Now, there's different types of nephrons. Most of your nephrons are what they call cortical nephrons, and they have very short loops of Henle. Most of those are found in the cortex. 85% of your nephrons are cortical nephrons. Now, there's a small percentage that are called juxtamedullary nephrons, and they have very long loops of Henle. And you'll see they have this blood vessel that goes around them. This series of blood vessels is called the vasa recta. We're going to find out later on that this is where you actually are able to retain more water. So this 15% of the nephrons is important for water conservation. These ones with the short loop of Henle, they're more important for reabsorption of everything else. Now, remember this point. 180 liters of fluid derived from plasma. That's over 40 gallons of fluid. That's not going to all go out as urine, right? You'd be on the toilet all day if you were peeing out over 40 gallons of fluid. Over 99% of what is filtered through these nephrons, these little filtration units, 99% goes back into the blood. So everything that's filtered through goes back in. So that's really important. Another thing is, everything filters through with the exception of proteins and blood cells because they're too big to get through the filtration units. So you filter through a lot, 180 liters of fluid derived from plasma, but 99% gets reabsorbed back into the bloodstream. So that means on the average day, you're only going to urinate about 1.5 liters of fluid. That's about 1% of all that 180 liters that's actually filtered through. So 180 liters of fluid processed daily, only 1.5 liters goes out as urine. And there's 3 processes involved in urine formation. I want you to know that this takes place over about 4 pages of the notes. There's a lot involved, but just to summarize it, 3 processes occur in the formation of urine. Glomerular filtration. That is the filtering of the plasma through these little filtration units called the nephron. Then you have tubular reabsorption. So that's taking the substances from the tubule. After the plasma is filtered, it goes into the tubule, and then it's reabsorbed back into the blood. Now, most of your reabsorption occurs in the proximal convoluted tubule. So that's from the filtrate back into the blood. That's tubular reabsorption. Filtrate back into the blood. Tubular secretion is when things are passively absorbed back into the blood that really don't belong there, because sometimes you'll find urea is going to get drawn back into the blood, sometimes drug metabolites, things like that. But later on in the process, down in the distal convoluted tubule and the collecting duct, what's going to happen is those things get secreted from the blood back into the filtrate so they can be removed. So these are the three processes: the filtration at the capillary bed, reabsorption from the filtrate back into the blood, and then things that get passively reabsorbed during the reabsorption process that don't belong there, they're secreted from the blood back into the filtrate to go out as urine. And that happens at the other end of the kidney tubule. So we're talking about probably at the distal convoluted tubule and collecting duct. So here's a look at just a really short little cartoon picture of the three processes. There's the capsule, also called Bowman's capsule. Some places call it Bowman's, but it's the glomerular capsule here. So cortical radiate artery, afferent arteriole coming in, efferent going out. And that's filtration. And that's your at the glomerulus. That's step one. Step two is, here's your filtrate. That's a little short picture of the tubule. And so 2 is tubular reabsorption from the filtrate back into the blood. And these are the paratubular capillaries that surround the tubule. And then tubular secretion later on from the plasma back into the filtrate to get rid of substances that really are not supposed to be there. So the filtration membrane, where this filtration actually occurs, it's very porous. It's between the blood and the interior of the glomerular capsule. Small things will pass through. Water, solutes, smaller than plasma proteins pass. Normally no cells pass. So just remember that plasma proteins and blood cells normally don't get through. If you've got blood in the urine and you've got a lot of protein, then you've got probably a kidney infection, kidney disease, something like that. It's not normal. Now there's 3 layers to this filtration membrane. These capillaries are fenestrated. Fenestrated capillaries have pores, so they're more porous. They can actually withstand a higher pressure, and this is going to be important later on. The basement membrane is the fused basal lamina of the 2 other layers, and then you have these foot processes of podocytes. These have filtration slits that allow more filtration. They're also more porous. So this is a look at Bowman's capsule or the glomerular capsule. This is the visceral layer. This is the parietal layer. This layer attaches to the capillaries. There's your afferent coming in, efferent going out. Now I want you to pay attention to the size of these 2 arterioles. This one is much larger in diameter than the one going out. That increases the pressure in here. So when we talked about systemic blood pressure, we said that in the capillaries it's about 20 to 30 millimeters of mercury pressure. In the glomerulus, it's about double that. It's 55 to 60 millimeters of mercury pressure. And that's to push out this fluid. Under greater pressure, you can get out this 180 liters of fluid each day. So the increased pressure makes this filtration happen a lot faster. This is a look at a piece of a capillary. There's your fenestration or pores. Here's your podocytes. This is the visceral layer of Bowman's capsule. So these are simple squamous epithelium that have these little feet. And these little feet interlink together, but they have slits in between, and that makes them extremely porous too. So you're going to be able to push through a lot of fluid under high pressure with the pores and these open slits. That's the filtration membrane. So here are the pressures involved in filtration. Remember I said the hydrostatic pressure, that's in the glomerulus, is quite high. and it's about 55 millimeters of mercury pressure that's pushing out of the glomerulus. Now, because there's a lot more colloid in here, there's a lot more solutes in the glomerulus, that's going to pull the water back in because you don't have that many out here. Remember, osmosis goes in the direction where the solute load is the highest, and because it's highest inside the glomerulus, you got a net opposing pressure, osmotic pressure of 30, but it wants to pull the fluid back in. As the capsule is being filled up, that increase in pressure in the capsule causes back pressure as well. But that opposing pressure combined of 45 millimeters of mercury pressure is not normally enough to overwhelm the hydrostatic pressure in the glomerulus pushing the fluid out. And that usually is about 10 millimeters of mercury pressure. So what is really important is the diameter of this afferent arteriole. So by dilating or constricting this arteriole is how you're going to be able to regulate blood pressure. And we're going to talk about this a little bit later, but I want you to be aware of the fact that the sympathetic effect on this afferent arteriole is to constrict and lower the hydrostatic pressure, which is going to slow down filtration and urine production. The parasympathetic effect, remember, that's when housekeeping chores are being done. That opens this up. That dilates this vessel, which is going to increase the pressure and increase filtration and increase urine production, which is normally what happens during the parasympathetic system's activity and making urine during that time. So just keep that in mind. Now, glomerular filtration rate. This is the volume of filtrate formed per minute by both kidneys, normally 120 to 125 milliliters per minute. Now, here's where the number 180 liters comes from. If you take 125 times 60 minutes per hour, that's 7.5 liters. And if you multiply this times 24, there's where your 180 liters comes from. Now, glomerular filtration rate is directly proportional to how much surface area you have available for filtration. Now you have a lot. You got 1 million kidneys. You have 1 million nephrons in each kidney. So 2 million nephrons. And some people can survive very well with just one kidney. The filtration membrane permeability, much more permeable than other capillaries. And remember, the pressure that is very important. We talked about the opposing pressures, but it's this hydrostatic pressure in the glomerulus that's vital to making this process occur. Now, this is showing you the juxtaglomerular complex, and the only thing I'm going to say about this is that there are cells that are found in the afferent arteriole, and these are called JG cells. These cells produce renin, and remember what renin does. If blood pressure is low and there's not that much stretch being experienced here at the afferent arteriole, renin will cause the production of angiotensin II, which will increase the release of aldosterone, which will hold back more salt and increase blood pressure. So that's really what this is important for. So your extrinsic controls. Sympathetic system. If extracellular fluid volume is extremely low, like in the case of low blood pressure, norepinephrine is released by sympathetic nervous system, epinephrine released by the adrenal medulla, that causes increased systemic vasoconstriction, which is going to increase your blood pressure, and that constriction of the afferent arterioles decreases glomerular filtration rate, and because you're not filtering through as much blood and producing as much urine, you're going to increase blood volume and pressure. And this is what I was trying to tell you earlier, and I'm just reinforcing it here. Now, your renin-angiotensin mechanism. JG cells release renin. Renin causes angiotensinogen. This should be angiotensinogen. I'm sorry about that. And that's converted into angiotensin 1. And then angiotensin 1 is converted into angiotensin 2. And angiotensin 2 causes vasoconstriction, which increases mean arterial pressure. And the adrenal cortex releases aldosterone, holds back salt, which further increases your blood pressure. So that's the renin-angiotensin mechanism. All right, so filtration at the glomerulus. 180 liters of fluid derived from plasma every day, 125 milliliters per minute. Now we go to reabsorption. So where does reabsorption take place? Most reabsorption takes place in the PCT, all right? So your nutrients, glucose, amino acids, 65% of your salt and water, many of your ions, many of your electrolytes like bicarb and chloride ions and potassium ions, all those ions are regulated. All of your uric acid and 1/2 of urea, which is going to be secreted back into the filtrate later. This passively gets reabsorbed sometimes. So this is a little busy, but it's showing you here you have the sodium-potassium ion pump. Sodium is on an exchange with potassium. So when you are reabsorbing sodium and exchanging it for potassium, this provides the drive, the solute drive, to pull in other substances like glucose, amino acids, and some ions. And these go in as like a co-transport with sodium. And then here you can see the solvent drag here, solute drag there. So primary transport is your sodium and potassium. Secondary, all of your other substances. And passive transport by diffusion, water can go through aquaporins, lipid-soluble substances can pass right through the membrane, and some go through this paracellular route in between the cells and go back into the blood. But this is what happens at the PCT, where just about all of your reabsorption takes place. Now, there is a transport maximum for most substances that are reabsorbed, and that's due to the number of carriers that are in the renal tubules that are available for reabsorption. When those carriers are saturated, the excess is excreted into the urine. For example, if a person has hyperglycemia and they have too much glucose floating around in the blood, once those carriers to reabsorb it are maximized, then the rest spills off into the urine. And that's why you see a lot of diabetics that are uncontrolled have high amounts of glucose in their urine because they've saturated and oversaturated the carriers that are responsible for bringing the glucose back into the blood. Tubular secretion. This is where you actually take the substances that have been passively reabsorbed back into the blood, and you're going to get rid of those. So it disposes of substances bound to plasma proteins like drugs, eliminates undesirable substances that are passively reabsorbed like urea and uric acid, and you get rid of excess potassium. Remember I said sodium and potassium are on an exchange system. So the aldosterone effect is if you have secreted aldosterone to hold back sodium, you're going to get rid of potassium in exchange. And it also controls the pH by altering amounts of hydrogen ions and bicarb in the urine. Bicarb is a base, H ions are an acid. So if you need to increase the pH, you hold this back and you secrete this. If you need to decrease the pH, you hold this back and secrete that. Okay, so that's how it works. Okay, so reabsorptive capabilities of the renal tubules and collecting ducts. So we said the PCT, most absorption occurs here as previously mentioned. The nephron loop, the descending loop, water can leave, solutes cannot. The ascending loop, water cannot leave, solutes can. So that's very important. This is how we're going to determine how we can conserve water by using those juxtaglomerular nephrons, which we'll talk about a little bit later. So remember, water leaves the descending limb, solutes cannot. Ascending limb, water cannot leave, solutes can. Now, the DCT, the distal convoluted tubule and collecting duct, reabsorption is normally hormonally regulated. So in order to have anything happen here, you have to have aldosterone present. And with aldosterone, you will reabsorb more salt and therefore more water. Atrial natriuretic peptide, that is an antagonistic hormone which will cause you to remove salt and reduce blood pressure. And if you're going to be removing sodium, you're going to be retaining potassium. So this one antagonizes the aldosterone effect. An antidiuretic hormone, you're going to hold back water. Parathyroid hormone, remember, that's the one that we talked about back in bone chapter. We said that PTH breaks down bone matrix and releases calcium into bones. Well, PTH has an effect here at the kidneys by helping you hold back as much calcium as you possibly can. So this is kind of a summary of tubular reabsorption and secretion. So 65% of your filtrate volume is reabsorbed here. And your green is secretion. You do have a little bit of secretion happening here, but overall the main drive is reabsorption. Now, your descending loop of Henle, permeable only to water, so water is reabsorbed. Ascending loop, only permeable to salt. And then when you get into the distal convoluted tubule and the collecting duct, this is facultative. You need hormones present, like aldosterone, to hold back salt. Chloride ions will follow. Parathyroid hormone will cause you to hold back more calcium. And you have that aldosterone effect, the exchange of sodium and potassium here. If you're holding back potassium, if you're holding back sodium, you're going to secrete potassium, and vice versa. Here again, facultative reabsorption. So this is just something you want to look at to make sure you understand where the different processes are occurring in general. So what determines whether you're going to form a dilute or a concentrated urine? Well, the osmotic gradient is used to raise the urine concentration. Now, plasma generally has a solute load of 300 milliosmoles to conserve water. Now, that is what you have in plasma coming in to the kidneys. That's what's filters, okay? Now, if you're overhydrated, you have a lot of water relative to the amount of solutes, right? So you have a very large volume of fluid, and that's going to form a very dilute urine. Your ADH production is down, and so your urine can be as low as 100 milliosmoles, and if aldosterone is present and you're holding back more sodium, that can even make it more dilute and can be as low as 50 milliosmoles. So you're talking about something, urine, that's very, very water-like, and that's caused by overhydration. So dehydration, you produce a small volume of concentrated urine, so you usually have maximum ADH secretion, and you're holding back as much water as possible, and so your urine is going to be very concentrated and you won't produce much of it. And in severe dehydration, 99% of water is reabsorbed, and you probably won't be peeing very much at all. So now we're going to talk about this countercurrent mechanism. Now, the countercurrent mechanism is a mechanism that occurs when fluid flows in opposite directions in two adjacent segments of the same tube with a hairpin turn. That's by definition. So it's fluid flowing in opposite directions, and they're connected by a hairpin turn. Now, the countercurrent multiplier is the interaction of filtrate flow in ascending, descending lems of the nephron loops of the juxtamedullary nephrons. These are that 15% of the nephrons that their loops of Henle or their nephron loops are found way down into the medulla, and this is where water conservation occurs. Now, the countercurrent exchanger is by way of the vasa recta. This is the blood vessel that surrounds the loops, the nephron loops, okay? So the countercurrent multiplier is the nephron loop. The exchanger happens between the blood vessel that surrounds this loop. So here you can see it. There's your glomerulus, proximal convoluted tubule, loop of Henle, DCT, collecting duct. So the long nephron loops of the juxtamedullary nephrons create the gradient. They are your countercurrent multipliers. The vasa recta, countercurrent exchangers. And the collecting ducts of all nephrons use the gradient to adjust the urine osmolarity. Now you can see here it goes from 300 milliosmoles all the way down to 1200. And this changes as we're going through this countercurrent mechanism. Now let me show you in a little bit more detail here. This is the plasma coming in to the proximal convoluted tubule. As it goes down, remember the descending loop of Henle is permeable to water, so it gets more and more concentrated. Then you go to the ascending loop, and here only salt goes out, so you get less and less concentrated, and by the time you go to urine formation, look what's happened to the concentration, 100, okay? Now, your vasa recta coming in, going down, it's going in the opposite direction of the loop of Henle, nephron loop. The salt that's leaving the ascending loop of Henle can be reabsorbed into the vasa recta. So you can see it gets more and more concentrated, and as you get to the bottom, now you go around the hairpin turn, and the water that's leaving in the descending loop of Henle can get reabsorbed back into the vasa recta, and now you go back to the 300 that you started with. So it helps to equilibrate the water volume to make sure that it's where it should be. So diuretics are chemicals that enhance urinary output. ADH inhibitors like alcohol. Sodium reabsorption inhibitors, and they result in water reabsorption. Caffeine, drugs for hypertension or edema. Anything that blocks sodium will make sodium go out in urine, and when you're removing that solute, you're going to take a lot of water with it. Loop diuretics, as a classification of drugs, they work at the loop of Henle. They block sodium reabsorption, so that's going to cause you to produce a lot more urine and release a lot more water. Osmotic diuretics are substances that are not reabsorbed, so water remains in the urine. So when a diabetic patient is releasing a lot of glucose, you have a lot of water that goes with it to flush it out, and that's what results in the polyuria that you see with diabetics. So renal clearance is the volume of plasma the kidneys clear of a particular substance in a given time. And you can use renal clearance tests to determine glomerular filtration rate, to detect glomerular damage or follow the progress of a renal disease. Creatinine clearance is one that's done by the lab. You'll do a 24-hour urine collection, and then they can determine how much urine is actually being produced per minute, and then measure creatinine levels, compare that from what's in the urine to what's in the plasma, and see if there's a difference. And pathologies can be determined by elevated creatinine levels. It could mean kidney disease, it could mean a muscle wasting disease, like we talked about earlier. So physical characteristics of urine. If you're doing a urinalysis, you're looking at the color, you're looking at whether it's transparent or not, and usually urine is clear. It tends to be very pale, yellow, can be almost water looking. If the person's very hydrated, it can look like water. And then the more dehydrated the person is, it gets darker and darker yellow, and it can be more of an amber color. And the color is caused by urochrome, which is a pigment from hemoglobin breakdown. The more concentrated the urine, the deeper the color. There's some abnormal colors, and you can go online and look at these. There are some pathological conditions, and some drugs will discolor the urine. There may be some different colors that you may see. Urine has a slightly aromatic odor when it's fresh, but if it sits for a period of time, bacteria metabolize the solutes, and it develops kind of an ammonia odor when it's standing, because that metabolic process of breaking down proteins produces ammonia. Remember, we talked about that earlier, that amine group on the amino acids that make up the proteins can get broken down into ammonia, and then the liver converts it into urea. pH, slightly acidic. pH ranges about 6 to 6.5. Normally, this is what you'd see in the lab, but you can have a range from 4.5 to 8. An acidic diet with protein a whole wheat can drop the pH, so it's really important to know what the patient's diet is so you can get an idea of maybe what to expect for a pH. If it's a little low or a little high, could be a dietary reflection. Alkaline diet, vegetarian, or if a person has prolonged vomiting or urinary tract infections, that's going to increase the pH. Specific gravity is a unit that measures concentration of urine. These are the ranges, but these are extreme. Most urine samples, you'll see the value 1.020 to 1.010 to 1.020. That's where most urine samples, that's the range they normally fall into. If it's down here, that means it's very, very dilute, almost like water, because water's specific gravity is 1.000, so very few solutes there. And if it's 1.035, then it's really concentrated. And when something's this high in specific gravity, when you leave that urine sample sitting on the counter, it will precipitate out. It has so many, it's a usually very dirty collection. There could be a lot of debris there. There could be blood there, infection, a lot of white blood cells and bacteria. So that's very concentrated. Urine is mostly water, 95%, and 5% solute. And the solute primarily is urea. That's what makes up most of the solute load of urine, and it comes from protein breakdown. That's the largest solute component. You also will have some uric acid from nucleic acid metabolism, and creatinine we talked about earlier as a metabolite of creatine phosphate. Now, urine transport, storage, and elimination. So the kidneys are where the urine's produced, and then it leaves the kidneys and it goes to the bladder by way of ureters. And the ureters empty into the back of the bladder in the bottom, and by way of these openings into the back base of the bladder. Now, they're in a retroperitoneal position, and as the bladder pressure increases, as the bladder's filling up from the ureters conveying this urine into the bladder, the distal ends of the ureters will close. That prevents the backflow of urine. Now, homeostatic imbalance of the ureters and of the kidneys is called renal calculi. These are kidney stones that occur many times in the renal pelvis. And they're crystallized salts. Sometimes they have calcium, magnesium, or they could be uric acid salts. Now, large stones can block the ureter, and that can build up pressure and cause a lot of pain. Now, the cause of renal calculi may be due to chronic bacterial infection, urine retention, increased calcium levels in the blood, and increased pH of the urine, which makes it a more suitable environment for the stones to occur. The treatment is shock wave lithotripsy. This is by introducing shock waves. It's non-invasive. You shatter the calculi, so it makes it easier for a person to pass those. The urinary bladder is a muscular sac for temporary storage of urine. It's in a retroperitoneal position. It's on the pelvic floor, posterior to the pubic symphysis. Males have the prostate gland that's inferior to the neck of the bladder, and in females, it's anterior to the vagina and the uterus. And it contains openings for the ureters and the urethra. Now, the trigon is a triangular area that marks the place where the openings for the ureters and the urethra all kind of come together at the bottom of the bladder. And this area is important because infections tend to persist in this region. So the bladder collapses when it's empty. It folds into these little folds called rugae, and it expands and rises superiorly during the filling process without significant rise in internal pressure. And a full bladder is about 12 centimeters long and holds about 500 milliliters of urine, but it can hold twice that much if necessary, and it can burst if over-distended. There's a look at the female bladder. The wall has these interlacing bands of muscle that are called detrusor muscle, and these respond to stretch, and when the bladder fills and stretches the detrusor muscle, they contract, and that causes the increase in pressure and the urge to urinate. There's the trigon. There's the two ureters opening up in the posterior wall at the base of the bladder. There's the entrance to the urethra, so that's a triangle. That's called the trigon. There is the internal urethral sphincter. You do not control that. The external one you do, and the external one is around the area of the urogenital diaphragm. There's the male bladder, and you can see the position of the prostate gland here. And there's the trigon. So micturition or urination, voiding, another word, they all mean the same thing. But three simultaneous events must occur. Contraction of the detrusor muscle by the autonomic nervous system, opening of the internal urethral sphincter by the autonomic nervous system, and then you control the external urethral sphincter by the somatic nervous system. Somatic means you control it. And that is the end.